We're a year into the pandemic and we're learning a lot about this virus. And a big part of that comes down to data science. And that's where we're going to dive in today with our guest from the IU Fairbanks School of Public Health, Nir Menachemi. He is chair of the Health Policy and Management Department at the IU Fairbanks School of Public Health, also a scientist with the Regan Street Institute. And Nir, glad to see you back here with us again.
Good to be here. Thank you.
And I know you want to mention this. The IU Fairbanks School has a Fort Wayne office these days, a Fort Wayne branch. Tell me more about that.
Yeah, so the Fairbanks School is proudly on both the IUPUI and the IU Fort Wayne campuses, and we engage in both teaching students at the undergraduate master's level and doctoral level across the two campuses, and also engage in research and lots of work with both public health and health system and other stakeholders. And so we're very excited to be a new part of the Fort Wayne community at IU Fort Wayne.
And I think we now have a greater value of all the work of public health because of this pandemic, and particularly the research that you've done. You were head of a project, first in the nation, possibly the world, to get a random sample to really understand the prevalence of the virus. Can you recap the importance of that project and then where we're at today and what you've learned?
Yeah, and thank you. Thank you for the opportunity. We are extremely proud of the work we've done here as part of the Indiana prevalence study. And I have a couple of slides to really, I think, show the power of what we were able to do. So this is a pyramid, or if you can imagine a pyramid of everyone who's infected at any given time period with the coronavirus. And this pyramid is one that the CDC uses, but it includes all the way at the base of the pyramid, really probably a large portion of the people who are infected might be infected and not even know it because they don't have any symptoms. So they're asymptomatic. Right above them, the slice on the pyramid would include people with symptoms. They're probably mild symptoms, maybe a little bit of a fever, a little bit of headache, maybe the loss of sense of smell or taste, or something that isn't alarming that would get them to present to a medical setting. And the next rung above them would be people who present to a medical setting and ultimately get seen either at the doctor's office or the emergency department. Some proportion of them, which takes us to the next rung on the pyramid, now towards the top, some proportion would be hospitalized. And all the way at the top of the pyramid, the tip of the pyramid, some smaller proportion of people who are infected might die. And when you think about it, we are, since the beginning of the pandemic, been testing people, and there's been a shortage of tests at some, especially early in the pandemic. But every day we see on the news how many cases there are in the state, how many cases there are in the city, or how many cases there are in the US. But cases by definition are people who test positive. But if you think about the pyramid, the people at the bottom half of the pyramid who either don't have symptoms or have very mild symptoms, they never get tested or they don't get routinely tested. And so case counts never capture them. And when the pandemic first started, nobody really had a full appreciation for what proportion of everyone who's infected might be at that bottom half of that pyramid, which again includes the asymptomatic and mildly symptomatic individuals. And probably one of the reasons this has been such a challenging pandemic is because we know that the people at the bottom half of the pyramid are responsible for a lot of the community spread. People who are medically attended or are hospitalized usually have severe symptoms or serious enough symptoms to make them not be out and about, potentially spreading it to others. And so the worry has always been that spread is occurring unwittingly by people who don't know that they're infected or are dismissing their mild symptoms for nothing serious. And as a result, they go on with their regular day. And so the power of our study, which we've now done in Indiana multiple times, and certainly the first in the United States to be able to do this at this scale, is we randomly selected people from the population to test them. Instead of waiting for people to become symptomatic, we took a very large proportion of Hoosiers and invited them to get tested. And those that did were going to be much more representative of everyone who might be infected than relying just on tests that occur in clinical settings. And so we were able to generate for the first time the number of people who were infected in the state. And because we tested them both for active viral infection and for the presence of antibodies, we were able to determine the cumulative number of people who were ever infected in Indiana. And that allowed us to do some really powerful analyses and really provide information that I think has been uniquely helpful in Indiana and uniquely helpful to the world's, war against the virus.
Yeah, I think that's really interesting, and people probably don't get a full grasp of just how many of those asymptomatic and underreported cases were out there. Certainly the case with my illness. I played it off as something else and then finally got tested to discover the truth. What did your study show about how many of those people like me were out there?
Yeah, so one of the things that we were the first to basically determine, and in fact, the CDC in part has based their assertion on our data, is that roughly 40 to 45% of people who are infected are asymptomatic. And so that bottom rung of that hypothetical pyramid that I described is a big chunk, about, let's say, 40% of people who are out there and infected right now might not even know.
So your study was to have a fourth wave, and now you're telling me that because of your strategies and how you've manipulated data, you may not necessarily have to do that fourth wave of the study. Walk me through that.
Yeah, so because we have now done 3 waves, and every time we go out into Indiana, we do a new random sample, we test people, we figure out what proportion of them are currently infected, we determine which proportion of them have been previously infected based on antibodies. We've been able to sort of get that really important denominator at various different time periods in the state that tells us how close are we towards herd immunity. That denominator is the cumulative number of people who've ever been infected in the state. Now, besides knowing how many people have ever had the infection, it also allows us to very reliably calculate the probability of death or the probability of hospitalization, for example, among people who are infected. Because no one else has done these widespread random sample testing, it's been difficult, especially early on, to know what is the chance of death for someone who's infected. Almost all of the death rates we have seen publicized have been what is the death rate among cases. And remember, cases are really that top half of the pyramid. Cases are almost always conceptualized as the most symptomatic. So the death rate among people with symptoms or serious illness is not the same as the death rate among infections. Now, because we did the random sampling, we were able to determine the death rate at each age group. And so, we found out that overall in the state of Indiana, and we, sliced and diced the data in different ways. What I'm about to talk a little bit about is the death rate among people not living in nursing homes. And it's not to say that people in nursing homes aren't important to count and to understand, but one of the things that we did in our prevalence study for the state was to try to understand the risk outside of people living in institutions. So I'm really talking about people outside of nursing homes, outside of being incarcerated. And we found that for every 384 infections in the state among people who are not in institutions, we see about 1 death. But when we break it out by age, we get a completely different picture. People under 30, it's really about 1 in almost 20,000 that die. Whereas people over 65, the rate is much higher, like 1 in about 40 or 50 infections die. Remember, the rate among people with more serious illness will always be higher because it's only focusing on the sickest of the sick. And so with this information, which really I think is super important for understanding both people's individual risk and understanding what the risk of different populations are or what's going on in different communities. We were able to determine without testing anymore how many people have been cumulatively infected. And this is really some algebra. If we know that for every 20,000 infections under the age of 30, one death occurs, we can determine how many people have died in Indiana in that age group. And here's just an example. As of October 1st, 11 people, not in nursing homes, under the age of 30 died in Indiana ever at that point. And so if we know the risk is 1 in 20,000, roughly, you can multiply 11 times roughly 20,000 and determine how many infections in Indiana had to have occurred in that age group for us to have observed those 11 deaths. And when you do this for each of the other age categories, you can get a cumulative number of people who might have been infected in order for us to have been observing those deaths in each of those age groups. For example, as of October, the first week in October, a couple of months ago, over 1,000 people age 65 or older had died outside of nursing homes. Knowing that the chance of death among people infected in that age group is 1 in 43, you're able to multiply roughly 1,000 by 43 and get to this roughly 44 and change thousand infections to have explained those 1,000 deaths. Mm-hmm. And then when you divide all that by the population counts in each of those areas, you can get to what proportion of Hoosiers have ever been infected.
Yeah, I see how that works. So one variable there, though, it would seem to me, is if doctors and treatment improves, and so we're keeping people alive longer in the hospital, wouldn't that adjust your figures?
So it could, but it turns out that it's not 100% clear that we've been that much better at preventing deaths. Certainly, we're doing a lot better job at managing the disease, but it's not clear we've been able to avert deaths. I think our frontline healthcare workers, doctors and nurses have just become better and better at managing people. Maybe the average length of stay has gotten down, but people, as it turns out, that we're going to die, there's been not much that we've been able to do to prevent them from dying. But I think you're on the right track with the question. What has the potential to affect our calculations is at the point where we overwhelm our health system, and we've come pretty close to that in Indiana now several times, people who could have been cared for in a hospital bed that have to be turned away, that's where we are suddenly in, uncharted territory of, increasing the death count, not because, any other reason other than we don't have beds and people to care for them. And that's why it's been so dire. When our hospitals are overwhelmed, bad things can happen to people in the population.
So as we hear those daily reports and the Department of Health puts out its dashboard, which, I find very helpful and check it daily, what data point there do you think is most illustrative of exactly what's going on in the community and how I measure my risk?
So I agree. I think the dashboards are extremely helpful. I think Indiana has done a terrific job at getting information and being transparent about it as fast as possible. But even the best information is difficult for the average person to fully wrap their head around. And so I caution against any one data point that someone should hang their hat on. So case counts could go up. I think that's easy for people to sort of wrap their head around. But, the number of cases is sometimes obscured by how many people are getting tested and why they're getting tested. So, for example, if a university starts testing people on their campus to identify people who are asymptomatic positive, and the reasons for testing is not due to symptoms, but due to mitigation, that can affect your case counts because suddenly cases might go up, but that doesn't mean we have more infections. Likewise, if you only look at emergency department visits, that might miss all the people who don't have serious enough symptoms to go there in the first place. If you look at deaths, which I think is also really important, that usually lags infections. So, how long does it take someone who is eventually going to die? Somewhere between 3 and 4 weeks. So if you see a sudden spike in deaths right now, that means a month ago in the community, there were more infections raging, resulting in the deaths we're seeing today. And so you have to have this trained lens in order to fully characterize the picture. And there's no one data point that tells you everything you need to know.
So I'm tending to watch positivity as a key indicator because that seems like that is going to tell me a snapshot look at exactly what's going on. Is that, out of all those data points, is that the one that, if I had to press you to one, is that the one?
So positivity is a good one, but I have reservations about it. So let me give you a hypothetical. If suddenly we had a limited number of tests and less people were being tested, who would be tested the most with the limited number of tests?
Well,
Probably
people
the
who are
people
worst off. Yeah.
with the most symptoms.
Yeah.
And so the positivity rate will have to increase without necessarily telling us what's happening. And so as the supply of tests fluctuates over time and across time periods and locations, positivity rates mask what might be the underlying reason for the fluctuations. Now, generally speaking, I think we've had good testing supply, and that's improved over time. But if something would change there, positivity rates would suddenly become less reliable. Do you see the complexity?
I do. I do. And the complexity of this disease has been, obviously one of our big challenges all along. So now we're at the point where we have a vaccine and, we're making good progress, not as fast as some would like, of course, but still, what stats are you going to be watching to look for the impact of the vaccine in our community?
Yeah, and let me just say one last thing about the metrics before we talk about vaccines. And this is going back to something I've already kind of hinted at. I think hospital capacity and ICU bed availability is a super critical measure, in part because if we exceed that, or we get to the point where our healthcare personnel are so burnt out that, they just can't deal with the onslaught of more cases in the hospital, that's when we will turn for the worse even more. So that's an also important measure that I keep my eye on. And I just want to round out that conversation saying that one is also really important to keep an eye on.
So where do we look for that capacity? Is that in the number of beds in use? Is that in the ICU bed capacity report that's in the dashboard?
It is, but that's only half of the, of the equation, if you will, in part because we can have a lot of beds available, but if we don't have doctors and nurses because they've been on so many long hours and so many shifts and they're burning out and they themselves are unable to keep up, the number of beds almost doesn't matter. It's the number of beds that we are able to, staff with personnel that becomes an even more important question. And so beds and ICU capacity is one thing, but you always have to keep in the back of your mind, how well is your healthcare workforce doing? How are they, keeping up with the pressures? And it is extremely stressful. You see this on TV. The doctors and nurses are, doing extremely important work that I think more and more people are appreciating, but they can't go on forever.
Is there a stat in the dashboard anywhere that tells me that factor?
I don't believe so because it fluctuates. It's very difficult to tell in real time at the state level. Nurses at one hospital, for example, there might be more infections or there might be issues with, the ability to come to work. The same thing might affect physicians or others. But, all of that is in flux at any given time because of how much pressure the system is taking right now.
So let's go back to the question of the vaccine. Where are we going to see that first? What stat should we be watching to see its impact showing up?
Yeah, so the vaccine stats are going to be just as complex, but there's some stuff that I think are important to keep an eye on. First and foremost, I'd want to know how are we doing in terms of getting the vaccine out? Right now, we're focused on, people in that first category or two. What proportion of them are, uptaking the vaccine? How many people who are high risk, either because they're living in nursing homes or because of their age or because of their occupation, whether they're in an essential worker role, a frontline healthcare worker role, what proportion of them are getting vaccinated? Those are some of the things early on that I'd want to kind of, be reassured that we're doing well on and doing everything that we can. Of course, as we move from one phase of the vaccine rollout to the next, we'll want to see more and more things and different things that, will continue to reassure us that things are going well.
I get it that it's complex, but when will we start to see that impact?
So, let me kind of just share an old adage from public health that vaccines don't save lives, vaccinations do. And so we now have had a vaccine for quite a while. And if we can't get those vaccines into people's arms, it's not going to make a difference, no matter how effective or no matter what the efficacy of the vaccines are from a scientific perspective. If people don't get them, we're just not going to have, all the benefits that are of promise when we have a good vaccine candidate like the ones we currently do.
I gotcha.
And
I get it.
We need a lot of focus, and I know our state is talking about this. I know our health systems are talking about this. Just having the vaccine has been half of the battle. Now it's how do we deploy it? And so the deployment is going to be challenging because there's really not that much precedence for what we're trying to accomplish. I think Indiana has some advantages that we're a relatively, well-sized group that's organized enough with health systems that are strong enough with enough of a footprint and to work with other hospitals and health systems that could do this. And so right now we're working to sort of see how to work the plan and execute on the plan so that we can go from vaccines to vaccinations.
So lots of discussion about this new strain of the virus, allegedly more easily spread than before. The UK now in an extended lockdown. Gosh, we still see California having its challenges. Do you see anything on the horizon that makes you think that we're going to be kind of rolling back and looking at a more restrictive lifestyle?
So I hope not. And I think what we've all learned in the last, 12 months of the pandemic is that you never know what's going to happen next. I do know that we have lots of things in place so that we don't have to go back there if we don't have to. And part of that is accelerating the rollout of the vaccine. The sooner we can get to herd immunity, which we are not getting to without a vaccine, as I've sort of shared before with the data, or I guess what I never concluded before, or I stopped short of saying, is our best estimates as of the end of 2020, we were at somewhere at around 13 or 14% cumulative infection rates in the state of Indiana. In other words, how far are we from herd immunity, which might need 75 or 70 or 75%? We're at 14% at the end of December 2020. So we're not going to get to herd immunity very easily without the vaccine. I believe we are going to get to the end of the pandemic when we figure out how to get a maximum number of people vaccinated. And if there are any barriers along the way to people wanting to do that, we need to understand it so it could be addressed. I know that as soon as I am eligible for the vaccine, I will be first in line to get it. And I have read the data and I am familiar with both the drawbacks and the benefits, but the benefits outweigh the drawbacks in almost every sense of the word.
Yeah, I'm right there with you. The long COVID syndrome is frightening enough for me that I would jump on that. Do you have any thoughts about, so those of us who have recovered, and should we be at the back of the line? Should we voluntarily step back, or should we move forward? Just when our number's up, should we have the vaccine?
I know that there hasn't been enough determination, enough evidence on this. I know there's been some talks about from health officials around the world about, if you've been infected in the last 90 days or so, maybe you can wait, towards the back of the line. But I don't know that we know for sure. I know that people who've been positive are eligible for the vaccine and would still potentially benefit from it, in part because we don't know neither how long, having been previously infected, continues to protect you. And we also don't know how long having the vaccine will protect you. And so the longer we wait, the more complex it will be in terms of, everyone else who might have had temporary immunity. So I think a lot of those things still need to be sorted out. But right now, I think people who have been previously infected have just been soft recommended to wait. But beyond the 90-day window, I think people should go when their number is up or when their risk level is up and they're called upon.
What have we learned that puts us in a much better position for the next pandemic?
So we have learned a lot. I think the COVID experience has spotlighted a lot of the weaknesses in our public health infrastructure as a nation. And frankly, I think it's spotlighted a lot of the weaknesses in many, if not all of the states. No, I don't think any state has been able to weather this as ideally as some other countries, for example, might have been able to. Now, it turns out that the things that will help prepare us for the next pandemic are also the same things that will help prepare us for any chronic disease or any infectious disease. It's just raising the health resiliency of our population. And we can do that by investing more in public health programs, public health infrastructure, just making sure that people have better access to care, make sure that the things that exacerbate people's illnesses and diseases, which are usually social circumstances in nature, could be beefed up and supported in such a way so that they can better weather any disease, whether it's diabetes or depression or a future infectious disease in a pandemic. It turns out strengthening the public health system helps prevent a lot of the diseases and their aftermath in the future, pandemic or otherwise.
So once again, if the career in public health appeals to you, there is a program available here in Fort Wayne and also to IUPUI at the Fairbanks School of Public Health, where Nir Menachemi is Chair of Health Policy and Management. Nir, thanks for your time.
Thank you. And one last plug. We actually have 3 programs in public health on the IU Fort Wayne campus, several more on the IUPUI campus. But if you're interested in community health or health data science or health services management, all of which play important roles in a pandemic or in the public health infrastructure, please look us up.
Hey, thanks for your work. I appreciate your time.
Thank you.